Good morning, everyone, and welcome to the next session of CME Palooza Fall. I am Scott Kober, one of the co-producers of CME Palooza, and I would like to welcome you to this session. This is a repeat session from the last 2 years, different content, but same format. This session is called Common, Not So Common Case Conundrums in CME, and this session is sponsored by Peer Audience. As we do with all of our sessions, I'd like to start out by recognizing all 27 sponsors of CME Palooza Fall. So we have our gold sponsors, Genentech and ACHL, our silver sponsors, ASIM, Ethos CE Learning Management System, Forefront Collaborative, Integrity Continuing Education, Medscape Education, and Peer Audience, and our bronze sponsors, Answers in CME, Antidote Education Company, Catamount Medical Education, Clinical Care Options, CMEology, CME Outfitters, Creative Educational Concepts, Evolve Medical Education, Global Education Group, Helio.com Education Lab, Impact Education, Infograph Ed, Paradigm Medical Communications, Postgraduate Institute for Medicine, PrimeEd, Primary Care Network, RedMed Ed, RMEI, and Vindico Medical Education. So there are 3 ways to ask questions for those folks who are viewing this session live. This is the case with all of our sessions. So you can go to our live page and click on the Google slide link. You'll see a link for Scott sessions and a link for Derek questions sessions. This is a Scott session. So if you can click on the Scott session link and submit the question through there. You can also text us a question using the CME Palooza text line. The number is 267-6660-CME. That's 0263. Or you can tweet your question to us using the hashtag CMEPalooza. So just a brief speaker disclosure. So please note that the opinions, discussions, and or conclusions of our panelists are their own and do not represent an endorsement by or position of their employer, parent company, or affiliates. And with that, I'm going to introduce our first team. This is our medical education company team. This piece is being moderated by Allison Kickle. Allison is the Vice President of Education Strategy at Integrity Continuing Education, and she is joined by Tina Stacy. Tina is the Executive Vice President of Educational Strategy at Clinical Care Options. And the third member of this team, who unfortunately is a blue square right now, is Ali Kovacs-Lejeune, who is Ali is Executive Director of Impact Education, LLC. So we can see and hear Ali, or we can't see Ali. We can hear Ali, and she can hear us, so she'll be able to certainly participate in this session. So with that, I am going to turn this over to Allison to get us started with this first case.
Thanks, Scott. Appreciate it. All right, so assume you work for a mid-sized medical education company and you were recently awarded 2 fairly sizable grants, both from, let's assume, new supporters, Fuse Pharma and BZ Biopharma. Your initiative consists of multiple elements, which kicks off with a national satellite symposia. You have a series of 5 regional or relative state-based symposia at their annual meetings. You have a initial online education that's kind of a knowledge primer. And then at the end of your curriculum, you have a monograph that wraps up the key curricular takeaways. Throughout all of this, you have live and enduring, as well as a whole curriculum outcomes report. And one thing that's important to note is that throughout the education, your learning objectives remain consistent between activities and formats. You have a fairly similar audience between all the different activities. Your highest level of outcomes measure is level 5 performance measure. And you're measuring this through pre-tests, interactivity, polling question, post-tests, 45 to 60 day follow-up surveys for all of the activities, and a control group assessment. So this is a lot of outcomes. You're keeping your outcomes person busy here, as you'll have 1 report on your national symposia, 2 outcomes reports, 1 for your regional symposia, 1 that's an interim, since they're split between the fall and the spring, and we'll go over the timeline in just a second. 1 for the enduring knowledge primer activity, 1 for the monograph, and then 1 overall curricular assessment. And you're looking at the effectiveness of different formats for this audience group, as well as motivation for learners who completed 2 or more activities. So all of this part of the goal too, with the learning objectives remaining consistent, is that it goes into this global curricular assessment. So everything kicks off well. You start executing according to timeline. Your first enduring launches, and then your first regional symposia launches a few months later. And really, your goal here from a content standpoint is to take the learnings, the initial learnings from the learners of earlier activities, and apply them to the evolution of content for future activities. So things are moving right along, and this is the overall timeline. And you deliver your National Symposia Outcomes Report. This is your first report in the series of outcomes. And Fuse Pharma reaches out and says they'd like to present this to their execs, and they need you to pare down your assessment into a single slide, which I'm sure many of us have run into this before. What needs to be included on that slide are sort of the standard basics: grant ID, project overview, the title, the demographics for all participants, key findings, and then all findings from levels 3 through 5. And that has to be broken down by community of practice. So really academic versus community. Your original report was 15 slides. And in particular, your competence measures were pretty data heavy because you used a full case vignette. So you've got to get these 15 slides into one. So you need to decide what stays and what goes. I think for groups that are grant supported, this is a very common conundrum and something that we're dealing with. And keep in mind, this is multi-support. So Allie, I'm going to tee it up for you. What stays, what goes?
Yeah, so this is pretty common. And also I apologize that I don't have video. I promised Tina I didn't do it on purpose. So so this is a pretty common request that we get. And what we've moved to doing is using an infographic for our executive summary slide. And I think it's a great way to fit a lot of information on the slide, but still make it visually appealing and user-friendly. And I think if you're thinking of the end user for this slide, the supporter is going to have a limited amount of time to present the key findings, and an infographic would really help. I think to add the additional detail that you'll need, especially with the case vignette, that you should really use the speaker notes. And you want to provide the grantor with the key takeaways on that slide, and also detail out what those case vignettes are. So if they're presenting this, they'll have that as background information.
And do you give the supporter your contact any sort of background, or they're just used to seeing this, or do you direct them to the notes so they have any opposition to reading through those?
Yeah, whenever we can, we request a conference call or WebEx to present the slides before they would then use them. If that's not possible, we do include on the cover slide a note in the footnote that says, please note speaker notes are on slides 1, 2, 3, 4, and 5. And then that will, guide them to where to look for additional information.
Great. Those are great suggestions. Tina, anything to add?
I think the first step that we would do when provided this opportunity would be to take a step back and think about the data, which actually highlight what the effectiveness of the educational activity and the goals and the impact on improving patient outcomes. So to make sure we're very succinct in the presentation of those data, but then also recognizing that through the course of data presentation to this supporter, both supporters, that this one summary slide, executive summary, will evolve, knowing that there'll be different time points with which the data will be provided.
Yeah. And then, and that speaks to what happens in the future. So do you amend any of the outcomes questions, the format of questions for future activities? Because keep in mind, you've really only executed about half of your initiative at this point. So it's a room for opportunity, but what is that opportunity? Tina, can you speak to that, kind of pairing off the last question?
Certainly. So recognizing that this is multi-support, we have to be cognizant of the reporting needs for all of our supporters, but also as the provider, I feel confident that we will have thought from A to Z from our program. So at its inception, we're thinking about what the educational goals are and the outcomes that we look to provide. So I can't say that getting this particular opportunity from Fuse would necessarily change the questions that we're asking of our learners in order to provide our outcomes data. But it definitely would reframe how we're thinking about presentation of those data moving forward.
Yep. And Allie, from a communication standpoint or from amending outcomes for the future, do you have any comment here?
Yeah, I think that it depends on what the change is, but in some circumstances, we've actually gotten some great ideas from the feedback we've received from grantors. So if it makes sense to make a change globally across our activities in the format in which we develop outcomes, but also report on them, I think that makes sense. I think you just have to look at the activity you're working on. And as Tina said before, you have to revisit what was proposed, because there was a whole needs assessment that went into helping develop your outcomes design. So you want to make sure you're still aligned with that and not making too many changes, because again, with this, you have a curricula assessment at the end of it. So you have to be able to measure these things across all the activities.
Yep. And if you drop off one, what does that mean? If you edit something for one of them, what does that mean for your final report? Which was, I will also note, was of high interest to the supporter, because they're trying to evaluate formats and they want to do it in an independent way. And this is part of meeting those objectives. I'm going to bounce around in the questions a little bit, because I think it's a good time to address. Some folks might have dealt with this in their own practice before, but if you have the late realization, you're sitting in one of your live meeting sessions and you realize one of your pre-post test questions is really not on point for your audience. For example, maybe it was written for more targeted for an academic audience and you're speaking to a community audience right now. Any suggestions on what to do? Because you're sort of in the middle of it right now. Tina, you're smiling, so I'm going to hit it to you.
I feel like this is my life. Yes. So you fix it. So I think that's the beauty of this opportunity, is you recognize that the question just really isn't on point to appropriately evaluate the effectiveness of the activity. I would, however, provide those data to the supporter, maybe in the appendices that goes with that executive summary, being very transparent that our learnings from that first activity showed that maybe there was confusion about the question, or just the development of it just wasn't on point, and evolve from there.
And I think you can also get to the same nature of the question and change the question. So it's not really causing a huge fundamental shift. I mean, I think Absolutely. With writing test items, so much is just tricky wording, but you're still getting to the same key point. So That's right. Yeah, great point. Allie, can you do anything to avoid the need to create unique outcomes report for every funder? I mean, you've got two supporters.
I'm sorry, I lost.
Oh, are you there?
Yep, I hear you now.
Okay, great. So I was just saying, how do you get around the fact that you're creating 1 million outcomes reports for this initiative? I mean, basically you've got, we've got 6 total. And considering multi-support, you're really at 12 outcomes reports. And this is for one initiative. While it's large, it's a lot of resources for a single company. Anything you could do to avoid all those customizations?
So I'm not sure you can avoid that the way things are set up now. But what I think you can start with, and what we do, is we start with a core slide presentation that has all of the outcomes in it, and then we're able to pull from there easily and customize that for each of the grantors' reporting requirements. And I think that right now, maybe Tina has a better suggestion, but I think it's very hard not to have to customize them, because every supporter has a different way they want to see outcomes, and some are submitted online, some you can email, and just from a basic format and delivery, it really does vary across the board. But I think the core content of that one presentation will help you, and you can easily pull from that, and that may save you some time. I do think that it is worth stating if, you know, the number of reports and the frequency of the reports is much greater than what you originally thought they were going to be. I think it's okay to communicate that to the grantor, just so they know for future activities, you may need to adjust your budget line item to account for the extra time that's needed there.
And do you adjust your timeline at all for reporting?
I think so. I think one thing that, you know, it sounds simple, but I think everyone needs to do a better job of doing this. Once you have the LOA signed, you know, there's a lot of work that goes into getting your activity off the ground, and timelines do change. And I think we all need to do a better job of communicating those timeline updates, because those will then impact when your outcomes reports are due. And most grantors have, you know, an automatic reminder that goes out from their system. And you don't want to be surprised 6 months later when they're asking for an interim outcomes report and really your activity just happened next week. So I think there's more communication that we can do to make sure everyone is on the same page.
And I think that's a challenge for, I would say, for supporters and for us. So if any timelines change, even if it's by a week, the grant system's going to say something wrong. And then I've had, you know, acceptances of change of scope take within the system after they've been approved, and actually the date doesn't update. And then so it really, I mean, there is an administrative burden. I wouldn't say it's huge, but it's something you need to track and follow. And I know if you're tracking it manually, that's got to be a real challenge. If you're tracking it through a database or some sort of CRM that's automatically telling you, hey, this is due. I don't know. I like to have technology do work for me, but I think that's something to consider too, because this is a lot to track. Tina, from a communication standpoint or from being proactively managing it, is there anything we could have done better to avoid the situation?
I think communication up front is vital, as Ali mentioned. And I would also state, as you mentioned, the support of technology, that anytime that you can invest in technology to support these processes and customizations, highly recommend that, because it'll certainly save a lot of time and individual effort.
Yeah. And then if you have technology that sort of advances dates for you, if you change one, I find that really helpful. All right. So assume we have this problem fixed for right now. And don't forget to submit questions should you guys have any. But as soon as you sort of deal with this, your other supporter gives you a buzz and says, hey, I'm sending out an email in just a moment that's going out globally to everyone we've supported in the past 12 months or 2 years. And they're strongly recommending the inclusion of a set of 7 standardized outcomes questions in all future outcomes reports. This is assumed effective immediately. And I put in quotes recommendation because, you know, it's going to be challenging not to do this for future funding, but it affects 3 of your future outcomes reports, including your curricular assessment. So you look at the questions side by side versus your survey questions, and only 3 of your existing questions actually align with the standardized set, close enough that your outcomes person feels like they can just overlay on each other. To add to this challenge, adding 4 questions to your pre and post test would bring your question total to 12. And for anyone who's taken at least an online activity or even a live activity, to blow through 12 questions, I mean, that's going to take a lot of time and you're going to drop off a lot of people. So how do you deal with this? How do you address the situation? Ali, what do you do?
So I think this is tricky because, again, you want to have a clean curricula assessment. And if you're making changes halfway through, you're just not going to have as much data to compare pre and post. I think you just have to do it. And I think you have to add those in. But again, I think it's worth having a conversation with the supporter who's requesting this and just, you know, being transparent and saying, you know, this does add to our timeline, does add to our budget, but also it's not going to, we won't have as much data, just to set expectations at that point versus trying to explain it at the end, which may be a year later and no one will remember that this was something that happened in the middle of the activity. So I think just being transparent and trying to work, you have to work closely with your web programmers as well if you're making these changes to the enduring activities to make sure that when you make these updates, you're not losing any previous data. So you'll kind of have all the data you need, and then you can slice and dice it how you need to.
So Tina, Allie, or from the hospital group, feel free to chime in too. Has anybody pushed back and ever said no? Like fully said no? I haven't.
No. I haven't really received any, any recommendations that are so strongly against what we were already doing.
So how do you manage, Tina? How do you manage survey fatigue? 12 questions is really onerous. So what do you do?
We have to think creatively. So it's not mandated that all of those questions are asked before the activity, at the end of the activity. I think we need to think about how can we effectively intersperse them within, whether it's the live or enduring program. Are there questions and technology support that can be asked, especially in a live setting, before the actual content begins? So before your your speakers get up there to speak, are there some canned questions that can kind of self-push, if you will, so that people can answer at their leisure instead of kind of feeling the pressure of answering them within a set window of opportunity? And then also, can some of the questions be answered as a follow-up survey, because it provides an additional touch point with your learners, additional opportunity to maybe reinforce the education that they were provided to help them then integrate it. And so maybe a follow-on survey a couple weeks or even a month afterwards.
That's great. And I know in our planning discussions for this talk, one of the things that we talked about is different mechanisms in which you can get more evaluations, more surveys, more responses just in general. And I think too, you need to think about your audience. So we talked about, okay, we're going to do paper forms. We're going to do them here. We're going to do them there. It really, if you know your specialist or your target audience really, really well, you can perceive their needs and what they're going to be the most motivated to respond to. So I think that requires a consideration as well. And then I think a follow-on, and we sort of saved the big question for the very end, because this is fairly contentious. I think in my time in the CME industry, I've received this request a few times, and there's nothing a supporter could do to avoid this coming midstream in programs. So, obviously they're trying to evaluate their entire program and want some consistency and standardization. One of the things I think as a group we're looking forward to is the group Brian's working with and the steering committee, and how they're going to standardize some language, because that's a consistent challenge for everyone. But a big question is how much input should supporters really have in outcomes design and assessment? How much leverage do they have in a compliant way? It's sort of a philosophical question, but Tina, any thoughts there?
Oh, thanks for sending it my way. At its core, I feel like this question is really a question of independence. However, as Allie mentioned, we've not received any recommendations for additional outcomes analyses that have just been like, what are we asking by any means? So we take the opportunity to think about, with the either the additional questions or the executive summary, how can these opportunities help us further improve our outcomes analyses and the way we report them? So, I think we as the provider have to take a step back and recognize that we have to think again from plan to execution and analysis of our activities. We cannot allow the recommendations to take over or supersede our outcomes analyses, but how can they be used to augment the analysis?
And I should clarify too, these have never been what I consider content specific questions. They've been more genericized in the way of, some of this you might already be asking in your evaluation. that's a good place to look too. Were your speakers effective? Right. There might be, how many patients are impacted. But Allie's assuming the questions are not content specific. And I know that's a flexible term, content specific, but how do you feel about this independence standpoint and how much feedback the supporters can have in this process?
Sure. I think what's most important, and Tina mentioned this, is to go back to, you had a rationale for your original design. So you don't want to drastically change that, or you're not really going to deliver on what you said you were going to in your proposal. So I think you need to look at, are the changes really changing your design, or is it just adding to it and you need to make adjustments? And I think that's fine. I think on a positive note is that these supporters are seeing so many different kinds of outcomes reports across many vendors, organizations, and they're seeing best practices. And if they can share those with us, I think that really only helps us. And it helps us create better reporting and better ways to share our data. So I'm kind of, I think it could be a positive too.
I completely agree. I feel just in general, we don't have enough forums for best practice sharing. And I think if we think more collaboratively across the different stakeholder groups, that's a real benefit to everybody. So that's a great point you raise, that they have a perspective that we can't possibly have sitting in our seats. And so it's definitely at a minimum worth listening and hearing that rationale and trying to take away some best practices. Any other thoughts you guys wanted to throw in before we kick it off to the hospital group?
Yeah, I would just say, thanks for having us on this. I thought it was really interesting, and it got me thinking about how I would handle some of these situations. So thank you. And sorry, Tina, I made you be on camera the whole time.
Thanks, Allie.
All right. Well, thank you, guys. We did get a few comments and questions sort of along the lines of what you were talking about is the grantor having input on outcomes, designs, and questionings? Isn't that a violation of standards for commercial support? And I think you guys talked to that a little bit, in your discussion, and then some of the issues around over surveying your audience and kind of survey fatigue, as we all know, is a big issue with everything. So thank you to the Medical Education Company group, and now we're going to turn it over to our hospital-based CME group, and our panel for this piece is made up of Melody Farrar. Melody is the Director of Continuing Medical Education at Johns Hopkins All Children's Hospital in Florida. And then we also have Kaylin Parks. Kaylin is now the Physician Education and Medical Libraries Manager at Children's Healthcare of Atlanta. Just transitioned out of CME, but she's going to be putting her CME hat back on one more time for us today. And then finally, we have Stacy Weiss. Stacy is the Division Director of Continuing Medical Education at HCA Continental Division and HCA Health One LLC outside of Denver. And so with that, I am going to turn this over to Melody to get this second case underway.
Thank you, Scott, and thanks so much for involving us. I speak for Kaylin and Stacy. We're excited to be here and appreciate the opportunity. So our case today is you've just returned from running a large CME conference in Myrtle Beach, South Carolina. Your flight was delayed in Atlanta and you got home around midnight. Unfortunately, you have a committee meeting the next morning at 8 a.m., so you can't take the day off. Following the committee meeting, you sequester yourself in your office and try to catch up on emails, voicemails, and administrative work. As the CME director for your large health system, that includes several hospitals and outpatient clinics, the administrative work seems endless. You take a swig of that coffee, you take a deep breath, and then dive into your inbox. Your eye is drawn to an email marked urgent from Susie Simpleton at your affiliate Smallville Regional Hospital with the subject line, Dual Accreditation for Cardiology Case Discussion Series. You click the email open. Hi there, I hope you're well. I'll be in Jacksonville this next week, so let's grab lunch and catch up. I have a quick question for you. Dr. Bob Smith, the head of our cardiology department, scheduled Dr. Jim Dansberger, a cardiologist from Upstate Memorial Hospital, to present next Friday on new approaches to the treatment of heart disease in women in our cardiology case discussion series. When we asked for Dr. Dansberger's disclosure, he mentioned that he had already provided it to Lisa at MedEd Advisors. When I asked him who MedEd Advisors is, he let me know that they are the ones accrediting the presentation and covering his travel and honorarium. They also said that they are paying for the catering for cardiology case discussions. I was thrilled to hear that someone else will cover our costs for this program because, as you know, our budget is tight. So here's my question. We usually provide the CME certificates for this program, and our doctors can download them from our Cloud CME software. Should we dually accredit this course in addition to MedEd Advisors accreditation so that our doctors will also have a record of their credit through Cloud CME website? Thanks for your guidance, Susie. So our questions for discussion, we'll start with, are there any red flags that go up for you related to this email?
Melody, I'll kick it off. It's Kaylin, and I identify with this case study. One reason being I live in Atlanta, and I often get stuck in the Atlanta airport. So I can identify that. And also, my budget is tight. So, and this person in the case example, their budget is tight too. I'd first say my biggest red flag when I read this email was, what is the educational need for this activity? You know, why are we approving CME credit? Is there really an educational need? And I think that's a good question that you could go back to, I believe his name is Dr. Smith, who's the head of cardiology, and say, can you provide me with the details of why this activity is needed in the first place? It sounds kind of nerdy and basic, but it's actually, we have to ask that question as CME experts.
I agree, Kaylin. Stacey, anything you want to add to that?
No, I absolutely agree as well. That would be my first go-to as well.
I think too, I would have to go back and ask, who is MedEd Advisors? Who is this entity? You know, who are they and what are they exactly providing?
I think that's a really good point. I think one of the red flags that would come up for me is the timeline. So, you know, we're just hearing about this and it's happening next week. So I think that weighs into the conversation as well. So what further information would you ask Susie to provide at this point? Stacey, do you want to jump in on that one?
Yeah, I think what I would probably ask her is for the disclosures from every single one of the providers who is going to be a faculty member in this particular course. And then additionally, I probably would want to talk to whoever was in charge of planning this. I know that Susie is kind of the liaison and the go-between, and I probably would want to go directly to whoever is the one in charge of planning.
I totally agree, Stacey. I love Susie Simpleton, is her name, but I would maybe bypass her and go directly to the physician lead and talk with them. And if I felt like I needed some backup support, I'd probably text my medical education chair or my CME committee chair, physician chair, if I felt like I needed some peer-to-peer support. I would maybe have that phone call, all three of us together.
Absolutely.
That's a great idea. And I think one of the things that often weighs into this is the stakeholders who are involved. And we know the pitfalls of accidentally upsetting people like Dr. Smith, our head of cardiology, and how rough that can get very quickly. So I think that's a really good point of getting the key stakeholders involved who can understand your position and defend you if needed. So moving right along, does your facility allow external parties to accredit activities presented on your campus? And is there any formal protocol in place to spell out the requirements for such an arrangement? And before we jump into that question, feel free, Kaylin and Stacey, to speak to that from any level of experience, not necessarily where you currently are in your position.
Absolutely. And I mean, I'll jump in here. You know, your facility or wherever you're working makes a kind of a general business decision whether or not to work with those parties or not. And you know, in my experience, we never have really gone down this road to work with an external organization to provide education to our, you know, learning community.
Mm-hmm.
I agree, Stacey. We also feel that way. I think one of the biggest reasons we like to accredit our own content at our own facilities for our own providers is we have a process in place for content validity, for quality metrics and quality measures, and I'm able to guarantee that from my CME team. I'm not able to guarantee what MedEd Advisors is going to deliver. So I think I would agree, Stacey, that as a general rule and in our policy, we would say no at this point.
So in the interest of time, we're going to move on to part 2 of the case discussion. And so after you follow up with Susie, you find out that Dr. Smith had received an email from MedEd Advisors offering to provide full funding for selected guest speakers to speak at Smallville Regional during their Grand Rounds meeting. This offer included coverage of faculty expenses, honorarium, catering for attendees, and CME accreditation. Dr. Smith selected Dr. Dansberger from the list of presenters and topics provided by MedEd Advisors, and MedEd Advisors handled everything else, including booking Dr. Dansberger's travel and ordering food from Panera Bread for this meeting. So what, if anything else, should you do at this point, considering this further information?
So I dust off that policies and procedures that you probably have saved somewhere, dust off the mission statement, and see, again, does this fall within your program scope and your program mission? Just a quick personal example, here at Children's Healthcare of Atlanta, our CME mission is to educate pediatric providers on pediatric topics within the state of Georgia. So a lot of times I have to push back to our physician stakeholders and say, how does your educational program help us meet our mission? And if it doesn't, then we really shouldn't accredit it. So I think, we say have these policies and procedures and mission statement in place, and they're just kind of there for accreditation purposes, but I think you could use it to really help you in this example.
Absolutely, Caitlin, I completely agree with you and what you just said. And also, aside from that, one of the things I was going to say previously is that it's always a good opportunity to kind of train the folks who are new to CME and, provide them with the education that they possibly need, similar to Susie Simpleton, giving her the kind of foundation of what a joint providership actually is and, provide the policies as well.
So do you guys feel that this type of arrangement falls within the ACCME and AMA guidelines and requirements, not considering the policy of your own institutions, but what's your thought on that?
So this case gives me a weird feeling. And I've always said, go with your gut. If you get in a scenario and it feels strange, it feels a little off, it feels like a potential compliance risk, you're having to continually go back to the guidelines and requirements, just say no. Just back out and, say this sounds great in some way, but we're not going to pursue this. And I kind of feel that way about this case. I get a weird feeling.
So
I'm with you, Caitlin.
I'll jump in on this a little bit. So my past experience also includes working with a medical education company. So I can easily switch hats between the hospital director role and the medical education company. And I think one of the things that on both sides, from the MEC side as well as from the hospital CME administrator side, gives me pause is this short timeline. So I believe very strongly that this certainly could be done within ACCME and AMA guidelines and requirements, but considering this is a week out, and we're just hearing about that, that is one of the major red flags for me. And I think if I were going to make a recommendation to MedEd Advisors, I would say you should have gone further up the flagpole before arranging this opportunity with Dr. Dansberger. So that's just one, my 2 cents worth from the MEC side of things. But certainly it can be done, and most of the medical education companies that we have partnered with, do everything above board and have outstanding programs that they offer, and they are not in any way, commercially biased. But I think one of the keys from my perspective is, following the money, looking at that LOA between Medan Advisors and the pharmaceutical company, as you mentioned, Kaylin, taking a look at the disclosures. Actually, Stacy, I think maybe you both mentioned that, but following the disclosure, follow the money on this one, and then also, how was Dr. Dansberger trained? Was he handed a slide set that he was required to present on? That might be problematic. So we'll run on to the next question. Can this session be dually accredited by both Smallville Regional and Medan Advisors? Or should you insist that your health, if you are going to proceed, that your health system accredit the program independently? Kaylin, we'll throw this out to you first.
So I agree, Melody, that I think that the tight turnaround is really difficult on this. And because of the tight turnaround and because of the weird feeling I get, I would recommend to Dr. Smith, the head of cardiology, that they move forward with the program. However, we would not accredit it for CME. And I would also ask that he ask Med-Ed advisors not accredit it for CME. They could continue, have the session, let it be an informational teaching moment, but it would not be accredited for CME. And, then I would also, if I get a little pushback from Dr. Smith or Med-Ed, I would advisors, especially with Dr. Smith, I would say, how could I help you? If this really is an educational need, how could our CME team here at our healthcare system help you deliver some education, some content that is accredited on this topic that you obviously feel like it's such a need? Hopefully that makes sense.
That's a great approach, Kaylin. Anything you want to add to that, Stacy?
Yeah, I completely agree with Kaylin and your approach as well. And I think, being stewards of the ACCME and, really implementing their policies and procedures is so important. But on the other hand, we also do everything that we can to eradicate any barriers that get us to say yes. So if there's a roadblock or a boulder that's between us and saying yes to somebody, we want to kind of go down every path and see what we can do. And then Kaylin, your recommendation for seeing what your system could provide, I think, is that eradication in full effect.
That's great.
So just one comment that I'll chime in on, and maybe Allison and Allie and Tina, you can also share your thoughts on this. Is I've been on the other end, and maybe you have been too, Melody, of receiving a grant for where we're going to be delivering 25 grand rounds at hospitals across the United States on topic XYZ, and then we've got to, after we get the funding, we've got to go find the sites. What are some ways you would suggest that a medical education company in such a position would reach out to a hospital, whether it's your hospital or another hospital or health system, to kind of make sure that everything is above board and that this can be kind of a win-win for both parties?
I'll jump in on that real quick, and I think that's a really valid point. And I've been on both sides of this. I've done this exact, you're contracted to do a certain number of grand rounds across the country. What I've found is most helpful on my end, as well as on the flip side from the MEC side, is get to the right people at the institution and have a conversation about what you have to offer and what's most important to me is how was the content developed and what was the process. So, I would want to see that LOA and those types of things. And as this case kind of alludes to, many of our hospitals within our systems have very tight budgets. I mean, many of my courses have very tight budget. So it can be an opportunity to bring in a well-known speaker who I wouldn't normally be able to afford in that situation. And for me, a lot of this is really about that timeline. What probably happened in this fictitious case is that Med-Ed advisors scheduled this months ago, but that Susie never thought, was not aware of it until this week, let you aware of it this week. So that kind of speaks to, it didn't get to the person in charge to approve it with enough timeline to consider it and make it happen in the correct way. So
then who is the right person to contact?
The head of the CME department is what I would suggest.
Okay.
I'm just going to throw in a quick thought. I think companies that do a lot of grand rounds, med ed companies that do a lot of grand rounds, this is part of the reason why they end up doing more and more and more. Because I think it's navigating that system and finding the right person who might have a different title based on different organizations. And so, you know, I have worked with groups who have done a ton of these, and I've worked with groups that have done, you know, this is sort of like a side, we do a few a year kind of thing. In the group I work with, we do a lot of these, and our project managers are incredibly adept at getting to the right folks because they have existing relationships. So I think you're absolutely on point, figuring out who the right person is, because they could have spent tons of time talking to sweet Susie, but Susie isn't really helping you out here. So I'm sure lots of med ed companies have dealt with this problem before, but yeah, I think scale of your grand rounds program is an important factor.
That's a really good point, and that's absolutely true. So here's a question. Our final question is it acceptable to have an outside entity provide food for this CME activity? And if so, what steps will be taken to ensure this program follows guidelines and standards of ACCME and AMA?
Well, here's my 2 cents. It's just food, and we are not in the catering business. So do we even need food? I mean, isn't it really about the education? So if you're getting hung up on food and who's paying for it, where's the check coming from, Panera isn't delivering on time, just mix the food and go with the education. I think it's important to help our physicians and our system realize, you know, really our efforts and our time and energy should be spent on the education. These logistical issues, either our team can work out, or you know, sometimes they're not needed to deliver high quality education.
Caitlin, I completely agree with you. That would be my take on that as well.
So one thing related to, is it acceptable? So let's talk strict policy. Since MedEd Advisors is an accredited provider, them providing food from a CME standpoint is absolutely acceptable. Now, if it were a direct pharmaceutical rep providing food without the firewall barrier of the you know, the CME accreditation, the accredited provider being in the middle there, receiving an educational grant through the right procedures, so it wouldn't be breaking any rules. But I totally agree, Kaylin, with you and with Stacy. I don't even know that I would mess with it. Because, you know, Kaylin, as you mentioned, is it even necessary? You know, it may be that this is a lunch program, in which case the food is always provided, but if food is always provided, then you already have a procedure in place for providing that food. So I would say that's in question, and that kind of boils down to how you as a provider want to handle that. But certainly, I think a lot of new to CME professionals get confused between, hey, somebody else is providing food, so it's absolutely illegal, we can't do it. That's not the case here, because we're talking about a CME provider that has received an educational grant from, you know, we don't even know who, but presumably a pharmaceutical company. So it's absolutely acceptable, but it becomes your decision whether or not you want to do that. Any other comments or questions related to this, Kaylin or Stacy? Anything else you wanted to add?
I don't think so.
Yeah, I was going to say, I think this is a common theme that we see sometimes across health systems. So I'm glad that we had the opportunity to discuss it.
All right, great. Well, thank you all so much for your time today. Thank you to both panels. Thank you to Allison, Allie, Kaylin, Melody, Stacy, and Tina. So for those of you who are watching this either live or the recorded version, there is a brief survey on the live tab. If you could go in and complete that just once, just one time. And it gives a sense of who's watching CME Palooza Fall. It helps us plan for the future. We always get some ideas for future sessions from people who participate in our survey. And for those who are viewing this live, our next session will begin here in about 10 minutes. Every session begins here right at the top of the hour. So you'll need to refresh your browser to view the next session. That should be queued up here in the next couple minutes. So once again, thank you to everyone on this panel. This is always an interesting discussion of some common case issues that that many of us face. So thank you again, and have a good day, everyone.
Thanks, Scott.
Thanks, Scott.